Hello, class. Hope all of you are doing fine and staying safe. In continuation with our microbiology class, today we'll be starting systemic bacteriology. Part of the systemic bacteriology is what I'll be teaching you on staphylococcal infections. Staphylococci is gram-positive cocci appearing in grape-like clusters. Okay. So today, after the class, you will be able to understand what are the virulence factors, the pathogenesis, clinical manifestations, lab diagnosis, and the treatment of Staphylococcus aureus infections, drug resistance in Staphylococcus aureus, and coagulase negative staphylococcal infections. These are the various topics I'll be dealing with in two classes. So today I'll be teaching you all about the virulence pathogenesis, clinical manifestations, lab diagnosis, etc. And in the next classes, I think which is tomorrow, we'll be dealing with the drug resistance and coagulase negative staph. Very important topic, often asked in your main questions and short essays. Definitely, you have this in practicals. There is one exercise based on staphylococcal infections. Okay. So, as I told you, Staphylococcus is a gram-positive cocci classified into two families, Micrococciae and Streptococciae. The species belonging to Micrococciae and Streptococciae. These are differentiated by a test called as the catalase test, where the species belonging to Micrococciae are catalase positive and those belonging to Streptococciae are catalase negative. This is a test done with hydrogen peroxide, where if you inoculate a colony of Micrococciae, you can see air bubbles being formed, which shows that it is catalase positive. Micrococciea catalase positive, gram-positive cocci arranged in tetrads or clusters. Streptococciea are catalase negative, gram-positive cocci arranged in pairs or chains. The family Micrococciea comprises of the genera Micrococcus and Staphylococcus. Micrococcus species are skin commensals not associated with human infections. They are about 1 to 1.8 micrometers in size and arranged in tetrads. Staphylococcus species are arranged in clusters. The Staphylococcus aureus is the most pathogenic species. It produces an enzyme called the coagulase, which forms the basis of coagulase test. Other species do not produce coagulase, and these are called as coagulase negative staphylococci, which are rarely pathogenic to man. Staphylococcus is named after the Greek word staphyle, meaning a bunch of grapes, and kokos, meaning berry shaped, by Sir Alexander Oxton in 1880. In 1884, Rosenberg named the species Staphylococcus aureus based on the characteristic golden yellow pigmentation of its colonies. Coming to the Staphylococcus aureus infections, Staphylococcus aureus is catalase positive, coagulase positive, facultative and aero, non-motile, non-sporing and occasionally capsulate. The spherical cocci is about 1 micrometer in diameter and they are arranged in grape-like clusters due to cell division in Staph aureus. It occurs in multiple planes with the daughter cells remaining attached together. So this grape-like cluster is due to multiplication or cell division where the daughter cells are still attached to the mother cells. It produces golden yellow pigmentation on nutrient agar and beta hemolytic colonies on blood agar. Most virulent species among Staphylococci produces infections and it ranges from localized biogenic infections to life-threatening systemic infections in man. So what are the virulence factors of this organism? Cell wall associated factors like peptidoglycan, teichoic acid, cell surface adhesins, protein A. The toxins include membrane active proteins like hemolysins like alpha, beta, gamma, delta, leukocidin or pantin valentine toxin, the epidermolytic toxin or the exfoliative toxin, enterotoxins, and toxic syndrome or toxic shock syndrome toxin. The extracellular enzymes include coagulase, heat stable thermonuclease, deoxyribonuclease, staphylokinase, and others like hyaluronidase, lipase, protease, etc. Now, toxic shock syndrome is self explanatory. I don't have to explain to you what is toxic shock syndrome. Okay? They release this enzyme which gives rise to toxic shock syndrome. As the toxin causes capillary leak, the aggressive parental fluid replacement and vasopressor to reverse the hypotension initiated at the earliest. Examine for or remove any colonized foreign body like vaginal tampon. Clindamycin is the drug of choice for toxic shock syndrome as it reduces the toxin synthesis. It is given along with anti-staphylococcal penicillin like cloxacillin, which is used for methicillin sensitive Staphylococcus aureus, which I'll be getting back in the next class. Okay, what is MRSA, what is MSSA, etc. Don't worry about that. Just remember that vancomycin is the drug of choice in cases of MRSA. MRSA is methicillin resistant Staphylococcus aureus, and MSSA is methicillin sensitive Staphylococcus aureus. For clindamycin resistant cases, you can use linezolid. Okay. Pathogenesis it colonizes Staphylococcus aureus colonizes in the anterior nares, axilla, and the perianal skin. It gets introduced into the tissue through minor aberrations or instrumentation and adheres to the tissue. It invades with the help of its enzymes. Evasion of host defense mechanisms. It is antiphagocytic because of the microcapsule and protein A. Inhibits leukocyte migration and the intracellular survival by formation of small colony variants. The metastatic spread is because of it spreads to various distant sites by blood or by hematogenous spread. Coming to the clinical manifestations, it gives rise to skin and soft tissue infections. It's the most common cause for the skin and soft tissue infections. So it can give rise to folliculitis, which is infection of the hair follicle, furuncle or boil, which are painful pustular lesions in hairy and moist regions. Carbuncle is a severe painful lesion in the lower neck area. Abscesses, collection of pus which appears painful and swollen, surrounded by erythema. Mastitis, breast abscess, impetigo. Impetigo mainly seen in children and appears as red sores on the face that burst and develop into honey-colored crusts. Surgical site wound infections, cellulitis or inflammation of skin and subcutaneous tissue, hidradenitis suppurativa, which is a recurrent follicular infection in areas rich in apocrine glands. Bortreomycosis, it's a mycetoma-like condition characterized by subcutaneous swelling, sinuses, and discharge containing granules. Coming to the clinical manifestations of the musculoskeletal systems, it causes conditions like septic arthritis. Most commonly involved joints are the knees, shoulders, hips, and phalanges. Osteomyelitis, again affecting in children, in long bones, and adults. In adults, it is vertebra. Pyomyositis, it is nothing but skeletal muscle infection, seen in tropical climates, usually seen in HIV infected patients. Abscess. abscess of the psoas abscess or epidural abscess. Affecting the respiratory tract, we have ventilator associated pneumonia in adults, septic pulmonary emboli, post viral pneumonia, empyema and pneumothorax, pneumostele, sorry, which is shaggy thin walled cavities in the lung in neonates. It can give rise to bacteremia and its complications like sepsis, septic shock, central line associated bloodstream infection or CLABSI for short. Staphylococcus aureus and cons are the leading causative agents. Metastatic foci of infection involving the kidney, joints, bones, lungs. Infective endocarditis, native valve endocarditis, prosthetic valve endocarditis, intravenous drug use as associated carditis, and nosocomial endocarditis. Affecting the urinary tract, we have urinary tract infections and pyelonephritis. Rarely, UTI is seen following instrumentation and insertion of catheter or implants. Toxin mediated illness, we have toxic shock syndrome, food poisoning, staphylococcus scalded skin syndrome. Infections associated with community acquired MRSA. I'll go in detail in the later classes. What is MRSA? Skin and soft tissues are the most common sites for colonization of community acquired MRSA. About 5 to 10% strains are invasive and it can be life threatening. Examples of this include necrotizing pneumonia, sepsis with Waterhouse-Friderichsen syndrome, or purpura fulminans, necrotizing fasciitis, the Staphylococcus aureus or Streptococcus pyogenes are the most common causative agents. So here you can see the folliculitis, okay, with the point of bulge here, and then here you have the abscess, which is the ruptured part. Epidemiology, it is part of the normal human flora. About 20 to 40% healthy population are carriers of Staphylococcus aureus. Most common sites are the anterior nares, oropharynx, followed by skin, vagina, axilla, and perineum. These colonization sites are the reservoir for future infections. Rate of colonization higher among the insulin dependent diabetics. HIV infected patients undergoing hemodialysis, injection drug users, and individuals with skin damage. Overall, Staphylococcus aureus is a leading cause of healthcare associated infections. Coming to the laboratory diagnosis of Staphylococcus aureus infection, direct smear microscopy by gram stain shows you gram positive cocci in clusters and pulses. Culture includes nutrient agar, where it shows golden yellow pigmented colonies. Blood agar, it shows narrow zone of beta hemolysis. Selective media such as mannitol salt agar, salt milk agar, and Lutlam's media. Coagulase smear microscopy is gram-positive cocaine clusters. The biochemical reactions, as I already told you, we have catalase test positive. Coagulase test, we have two type of tests, slide and tube. Both are positive. Protein A detection. Identification by automated systems such as Vitek and Malditov. Antimicrobial susceptibility testing. Here you can see the gram stain. This is from the direct smear. Okay, you can see the gram-positive cocaine clusters and you can also see the pus cells. Then here we have the smear from a culture. If you can see the arrangement of cocci in grape-like clusters. Then the Staphylococci colonies grown on nutrient agar. If you can appreciate the golden yellow colored colonies. Okay, this is what will be kept for your exams, for your practicals. The golden yellow colored colony seen in nutrient agar. And here you have the blood agar where you see this shiny zone, a clear zone. Okay, so this is known as the zone of hemolysis. This is because of the dying RBCs next to the bacterial colonies. So after those two important identification features, we have the coagulase test. Okay, coagulase test is to detect the presence of coagulase enzyme. Okay, and if it is positive, it will form a coagulum. That is, it will be semi-solid. Okay, coagulum. And if it is negative, it would still remain in a liquidy state. So coming to the catalase test, sorry, here they have again done a slide. This is tube coagulase, this is slide coagulase. So here you see the slide coagulase test where they add the patient sample onto distilled water from the colony. Sorry, not the patient sample. They take the colony growth into a drop of distilled water. They put this colony growth and emulsify it and mix it nicely. To this, they would add the antigen. Okay, so and if you see antigen to coagulase, and if you see there is, so in this test, I'm sorry I got carried away. Here what happens is, see, now you have the tube coagulase and the slide coagulase. Okay, so usually commonly what we do in our lab is the tube coagulase. So here in this tube coagulase, we would take a certain amount of distilled water, mix it with the patient's plasma, and then we take any plasma. Okay, and then we take the colony growth and inoculate it into this and leave it for 4 hours. Okay, if it is coagulase positive, then you will see a coagulum forming here. Okay, like a clot, you'll be seeing a coagulum forming. And if it is negative, the media would still be liquidy. For slide coagulase test, you take a drop of distilled water and then you take a single colony and mix it in that distilled water. To this, you add a drop of plasma. Okay, you drop a drop of plasma and then you emulsify it and look for any clumps. So if it is coagulase positive, you can see clumps forming within 2 minutes. Okay, you can see small clumps being formed, and if it is negative, you see nothing but just that liquidy state of the uh, plasma and the colonies. Okay, so what you have to mix here is distilled water, plasma, and the colony growth. The same thing here. To a drop of distilled water, you may take the colony and mix it, and then you drop a drop of plasma and emulsify it nicely. And within 2 minutes, you can see clots forming. Okay, or the coagulum. Coming to treatment, parenteral therapy for serious infections, we have for methicillin sensitive Staphylococcus aureus. Okay, the organism that are still sensitive to penicillin. We have anti-staphylococcal penicillins like nafcillin and cloxacillin. Vancomycin is inferior in terms of efficacy against MSSA when compared to anti-staphylococcal penicillins. Hence, it should not be prescribed for MSSA. Methicillin-resistant Staphylococcus aureus. For this, we have the drug of choice is vancomycin, 15 to 20 milligram per kg body weight, and the alternate drugs are discussed in further chapters. The empirical therapy for if you don't know the MRSA status, if you still have to wait for the lab reports to come and the patient is serious, you can start off with vancomycin with or without an aminoglycoside. Okay, vancomycin is indicated only if MRSA risk is high or if the condition is serious in cases of cardiac implants. Oral therapy for skin and soft tissue infections, if they are still sensitive to methicillin, you can give dicloxacillin or cephalexin or cefazolin. If they are MRSA, then you have to try clindamycin. And if it still doesn't work, you have cotrimoxazole, doxycycline, and linezolid. Drug resistance in Staphylococcus is mainly due to three factors. One is due to production of beta lactamase enzyme. The other is alteration of penicillin binding protein, and the other one is due to chromosomally coded gene called the MECA gene. Beta lactamase or penicillinase enzymes, these are secreted by Staphylococcus organisms. What they do is they cleave the beta lactam rings, okay? And the organisms producing these enzymes develop resistance to beta lactam. Resistant resistance can also be plasmid coded, that is, it can be transferred from one Staphylococcus aureus strains by transduction, and it is produced by more than 90% of Staphylococcus strains. The resistance can be overcome by the addition of beta lactamase inhibitors like clavulanic acid or sulbactam. Sometimes this organism also alters its binding site, that is, the binding site for penicillin, penicillin binding protein. Uh, I think coming to MRSA, I'll be taking it in the next class. Okay, so kindly go through today's class and we'll meet again for tomorrow's class. And if there's any doubts, please kindly message me on WhatsApp.